All right, good afternoon, everyone. We appreciate you joining today's webinar. We've got quite a bit of information that we want to share with you, and so we'll probably spend more than we usually do, a higher percentage of our time kind of going through some of the guidance that we'd like to give you all, but we will still have some time for questions. So again, we appreciate your time. My name's Ann Garvey with the Iowa Department of Public Health. Dr. Caitlin Pedati will also be joining me for this presentation today. This webinar will be archived after the session and will be sent out to registered participants so that you can review portions of it if you have to miss them or share with others that weren't able to join today. I want to start the discussion today by going over some new changes to our isolation and healthcare worker exposure guidance. We sent these documents out this morning to our local public health and hospital partners. They are also posted on the IDPH webpage. This is included in the procedure document for local public health partners. So the first thing I want to talk about is our isolation guidance for sick and or COVID positive members of the general public. And this guidance is it's basically the same as what we had posted previously with a couple of new nuances. As we move into the influenza season and we see more and more people who may be ill with things besides COVID, we think it's important to make sure, I apologize, I understand you can see this control panel box, so there you go. So as we move into the influenza season, we're going to see more and more people who may have symptoms that could be consistent with COVID, but could also be consistent with other illnesses. And so we felt it was important to clarify our recommendations for people who may have symptoms that could be consistent with COVID or with other things and who test negative. And so the big change here are the bottom two sections. So people who have symptoms of COVID-19, who are tested and who are PCR negative, and who are not close contacts of someone who has tested positive for COVID-19 can go back to their daily activities 24 hours, excuse me, I'm getting a pop-up box there. I apologize for those of you that saw that. But people who are not, again, let me start over. Test negative via PCR, who may have symptoms of COVID-19, who are not close contacts of persons who tested positive for COVID-19, can go back to their daily activities 24 hours after their fever and other symptoms resolve. Now, if we have someone who has symptoms of COVID-19, who's tested by PCR and tests negative, but who is a close contact of a confirmed COVID-19 case, they should continue to self-quarantine until 14 days after their last exposure to the confirmed case. Because, again, even if we rule out COVID as the likely cause of their current symptoms, they still could come down with COVID within that additional 14-day period of time. So we want to make sure that we're clear. If someone does have close contact with a COVID positive individual, they still need to carry out the rest of their 14-day quarantine period. So hopefully that's clear. Again, that's included in our guidance document that's posted on our website. Again, I would point out that we've also made it clear that people who test positive for COVID-19 on the serologic testing do not need to be excluded unless they're also positive on PCR testing. Again, we've talked about this on previous webinars, but serology testing is an indication of likely a past infection, and so we wouldn't require any type of exclusion or isolation for those individuals, again, unless they're also positive on PCR or have symptoms. So I'm going to transition here, and CDC has posted new guidance for asymptomatic healthcare personnel who are exposed to people who test positive for COVID-19. And this is a big change, and so I want to go through this pretty slowly. So CDC defines healthcare personnel as including all of the following. So EMS, nurses, nursing assistants, physicians, technicians, therapists, phlebotomists, pharmacists, students and trainees, contractual staff who are not employed by the healthcare facility, and persons not directly involved in patient care, but who could be exposed to the infectious agent that can be transmitted in the healthcare setting. And so this would include all of those personnel in the parentheses here. So clerical, dietary, environmental services, laundry, security, engineering, facility management, administrative, billing, and volunteer personnel. This does not include clinical laboratory personnel. For the purposes of this guidance, we would consider an exposure, a prolonged exposure, which is the wording that we'll use to differentiate what's needed, to be within 6 feet of an individual for 15 minutes. The other pieces of information on this slide that are important is that symptomatic individuals confirmed to have COVID-19 who develop symptoms, the period that we're worried about the individuals that they had contact with, there's 2 days before symptom onset until they meet the criteria for release, which would be the 10-3 rule, or the 10-day rule if they're asymptomatic. So again, when we have somebody who is infected with COVID in a healthcare facility, we're going to then go back and look at the 2 days before their symptoms started until they meet the 10-3 rule or the 10 rule. And that's the period of time that we're worried about finding those healthcare personnel that would have had potential contact with them. Now, for asymptomatic people, the infectious period is, for these purposes, going to be 2 days before they were tested positive through 10 days after they tested positive. Now, if these individuals had a known contact with a COVID-19 infected person, we should consider the infectious period to be 2 days after their exposure to that infected person. And I know that is really confusing and complex, so I apologize for that. It's kind of difficult to convey here, but hopefully when you review it in the guidance and review these slides afterwards, that'll make sense to you. If you have questions, please reach out. I'm going to try and go over it one more time. So for people who are identified as testing positive for COVID-19 in the healthcare setting, they're asymptomatic. If they had a known exposure to a confirmed case, we would go back and look for people that were exposed to that individual for 2 days after their exposure to the confirmed case until 10 days after their test was taken. So we'll try and clarify that. I know that's confusing the way it's worded in the guidance. If you have questions, let us know. The other components of this guidance are related to the use of cloth face coverings. We're really encouraging that healthcare providers use face masks, so procedure masks, and then also eye protection. If they're doing aerosol generating procedures, making sure they're using an N95 respirator. The guidance also acknowledges that if there are staffing shortages, it may not be possible to exclude exposed healthcare workers, so they can still work as long as they're using full PPE and they're being assessed for symptoms before their shift starts. One part of the guidance that we are amending slightly, in the CDC guidance, it's listing a fever as a temperature greater than 100.0. We just feel for the ease of making sure we're consistent with all other guidance, and all other guidance, CDC says 100.4. So we're going to just stick with 100.4 just to be as consistent as possible. But of course, we also would include subjective fever. There's some bullets here about people who may not present with a fever and using clinical judgment as well. Okay, now taking all of those things into account, I'm going to walk through the guidance documents. So if a healthcare provider had prolonged close contact with either a patient, a visitor, or another healthcare provider with confirmed COVID-19. And again, prolonged close contact is within 6 feet for 15 minutes. And that healthcare provider was not wearing a face mask or a respirator, or they were not wearing eye protection, and the person who has COVID-19 was not wearing a face covering or face mask, or if the healthcare provider was not wearing all of the recommended PPE while performing aerosol generating procedures. And again, when we're talking about an aerosol generating procedure, there's not a time period, it's just any aerosol generating procedure. So it doesn't have to take 15 minutes. So in those situations, we would exclude the healthcare provider from work for 14 days after their last exposure. We tell them to monitor themselves for fever and symptoms, and anybody who develops a fever or symptoms consistent with COVID-19 should contact, their healthcare provider, the occupational health program, to arrange for testing. So hopefully that's clear. Now, if healthcare providers had, other than those exposed and the risk above, there wouldn't be any work restrictions. So this is kind of confusing wording, but if you're wearing full PPE, there wouldn't be any work restrictions. We just recommend that you follow the recommended infection prevention and control practices listed here. All right, so hopefully that's clear. Again, that's in our guidance documents that are posted on our website. At this point, I'm going to turn things over to Dr. Padati to walk through our new long-term care facility guidance.
Okay, thank you so much, Dr. Garvey, and thank you to everybody who's able to join. And of course, as always, thank you for all the continuing work that you all are doing. We really appreciate it. So I'm sure that, many of you are aware that with Iowa this week, we've released some guidance to help sort of understand some of the guidance that came out from CMS and to talk through some recommendations around how to safely ease some of the control measures that were put in place around, this COVID-19 response. And this document also talks a little bit about testing, which we'll go through. And then also, this screen here, I just want to call to your attention that if you visit our webpage under sort of the coronavirus section, you should be able to find this guidance document there on the webpage if you haven't seen it already. So I'm just going to click the link and take us right over there so that we can go through it together. And so here is that guidance document, and I'm just going to increase the size here. So again, this is guidance that, parts of it will probably feel familiar. This is taking into account recommendations that came from CMS, as well as, taking into account a lot of hard work and great input, and we're very grateful to our partners, both at Leading Age and the Iowa Healthcare Association, as well as partners, with DIA and throughout the state who have helped us sort of put this together. So the idea with this guidance is to help provide for you something to start to think about when and how you might start to relax some of the control measures that were put in place for COVID-19. And so the guidance document is laid out in 3 phases, and it's going to talk through several different situations within each phase, and then at the end we'll talk a bit about testing. So the phase 1 section is really probably where most of us are at this point. So this is where we're seeing, increased spread in the community, the potential for, impacts on staffing and others. And so this is sort of, I would say, the closest to where we exist right now. And you'll see that reflected in each of these sections, beginning with visitation. So currently, you know, I imagine most places are following the CMS guidance, which suggests that in general, visitation is prohibited except for compassionate care situations that are related to end of life or specific psychosocial needs. And those are occurring under some pretty controlled conditions, and visitors are being screened upon entry, and we're using things like social distancing and cloth face coverings. And then in addition to that, you know, there are options, I would imagine, in many facilities for virtual visitation. And so I think that's pretty close to where many of us are probably existing right now. Then we can talk about, you know, visitation for essential and non-essential healthcare personnel. Again, you know, for the most part, trying to limit, as we've done throughout the response when we're trying to control spread, right, trying to limit non-essential entry, making those things virtual when at all possible, and when it is necessary, making sure that we're taking precautions. Again, similarly for these non-medically necessary trips, you know, utilizing telemedicine whenever possible, and then when it is necessary, you know, ensuring the use of things like cloth face coverings, being as safe as we can with transport and use of PPE and cleaning equipment, and keeping a close eye on individuals who are moving back and forth between healthcare settings. And then for communal dining, again, at this point, you know, I think many of us have adjusted that, so communal dining has not currently or recently been recommended, and if it is necessary, is being quite limited, using things like social distancing and limiting the number of individuals, and of course, as always, encouraging, you know, appropriate hand hygiene. And then screening, you know, here for residents and staff, you know, the recommendations that I think many of you are following. And then using source control like a cloth face covering, and making sure that facility staff and healthcare personnel are using appropriate PPE. And part of this appropriate PPE use, and we'll talk about this again and have kind of mentioned it already, but wanting to make sure that people are really using for healthcare professionals the recommended personal protective equipment. And so if that's not the case right now, or if you're still having challenges with access, we want to make sure that you're working, you know, either through your EMA or through other avenues to try and secure any PPE that you might be needing in order to provide care appropriately. And then when we talk about cohorting, again, you know, this is our idea that we've been following, where we have dedicated space and staff to try and manage our residents who are either symptomatic or positive separately from individuals who are negative or not symptomatic, and then also trying to manage new admissions or people who are moving in and out as sort of a separate group. And then, you know, restrictions around group activities that have been put into place, again, you know, using things like social distancing and hand hygiene and, you know, virtual or technology solutions where possible. And then, you know, in terms of testing, you know, wanting to think about, if you haven't already, you know, we would recommend that institutions, facilities consider completing a baseline testing assessment of all of their staff and residents. And we'll talk a bit more about that at the end. And then there's some guidance here related more specifically for DIA activities about the types of survey activity that will be pursued. And I won't go too far into that. And if there are specific questions for the survey activities or for CMS, for the DIA CMS requirements, we're happy to pass those along. So I think that, you know, that a lot of that will probably sound very familiar. It's probably very familiar to, you know, similar to what many places have had in place so far. And so when we start to think about ways to approach and assess readiness for relaxing some of those control measures, the things that we want to keep in mind include this list here. So we want there to have been at least 14 days since the last positive or suspected case in your facility. Want to make sure you're having adequate staffing, not experiencing workforce shortages. Want to make sure that you have adequate supply of PPE, that you're not having to function or operate on under any of that shortage guidance. Making sure that there are plans in place for hospitals to accept referrals and transfers, which is just getting at the idea that we want to make sure there's not a high burden on the area healthcare system overall. Wanting to be sure we're able to cohort residents with dedicated staff, And here's the sort of EPI criteria that we want to point out. We want to make sure that you're seeing a downward trend in the number of cases or the percent positivity over the past 14 days in your county. And that information can be accessed on the coronavirus.iowa.gov webpage, where you can click on your county and you can see the cases by date or the EPI curve, which would show you whether there's been a decline or increase, and then the percent positivity as well. And, you know, we're giving those two things because those are two of the metrics that have been used in a variety of federal documents and guidance, as well as by many other states, with the idea that what we're trying to understand and look for are decreases in activity as we've seen increases in testing capability. And then when we talk about the county, you know, the county level, I think, is helpful because it will give you an idea of what's going on nearby, but we also recognize that there may be facilities who might be sort of nearby a couple of counties or who may know that they draw from several other counties. And so the ability to incorporate what you think is appropriate for your area, you know, exists, you know, in this guidance and also in the website. And so, you know, I think I just want to point out that if you feel like you need to look a little bit at your surrounding areas and want to take that into account, I don't think that's unreasonable. And then, you know, we want you to be sharing your phase status through your regional medical coordination centers, which I know you've been responding to with a lot of information and continue to do that, and we're very grateful. We know that there's a lot of people asking for a lot of information, and we appreciate your time. And then just a note here that if you need to, you know, you can continue to use your discretion to be more restrictive in areas if there are reasons, you know, for your facility why that might make sense, and if there are questions or ways that you know, we can be supportive to you on that, you know, we're happy to have those conversations. So when we move into those categories that we reviewed earlier, you'll start to see some slight adjustments here. So, you know, including some ways to sort of allow for a little bit more increase in visitation, adding some specifics about whether you might want to do that by appointment or by limiting the number of visitors each resident might have in a given time period, and trying to incorporate things like open spaces or outdoor visitation when possible, and still making sure that we're doing things like screening and that we're, you know, trying to practice as many of those, you know, hand hygiene, and where appropriate and able, some of those virtual solutions are still an option as well. Similarly, you know, thinking about the essential and non-essential personnel, considering whether, you know, you're going to be able to safely allow re-entry of some of these individuals, including some of the barbers or beauticians, if they've been screened appropriately, if, you know, there's a limit to the number of people who would be interacting, if appropriate personal protective measures are taken, and, you know, things like wearing a face mask and utilizing hand sanitizer are followed. And then non-medically necessary trips, you know, again, you know, trying to keep in mind using a lot of what we've seen in phase 1, right? So we're using a cloth-based covering, you know, trying to use appropriate PPE and frequent hand washing is still going to be the recommendation there. Under dining, again, you know, still wanting to keep in mind some of those social distancing techniques, limiting the number of people in a group area, and then, you know, again, reinforcing the appropriate use of hand hygiene. And again, under screening, still performing some screening of residents and staff here, and also, you know, continuing those PPE recommendations, you know, using appropriate PPE when interacting with residents and making sure that, you know, those supplies are available. Again, similarly, as best we can, still continuing to do the grouping of individuals. And the cohorting here is going to be because we're in a situation where we should not have had a case for 14 days, right? So wanting to sort of make sure that we've got the area where if we had a case, you know, those are on their own, and then managing new admissions separately. Similarly, again, here, limiting group activities a bit, but, you know, allowing some small group activities with appropriate hygiene measures. And the testing, I think we can discuss a little bit more when we get down to the appendix. And then there's a note here about, you know, part of this will be recognizing that, again, as challenging as this has been, it's a little bit hard to predict exactly what the future will hold for us. So wanting to build in an understanding that as we loosen things, there may come a time where we may need to tighten things back up again. And so just keeping in mind that you'll want to have plans as we have enhanced testing and keeping an eye out for symptoms. We want to have plans for what we'll do if we do detect a case. And what we're going to want you to look out for is if you have a staff or resident who's confirmed positive with another individual who has compatible symptoms, we're going to want you to move back to phase 1 to start to tighten up some of those control measures. And the idea there is that if we're starting to see and detect increased activity, we're going to want to try and, again, tighten up some of those control measures to try and limit that from spreading throughout a facility. And again, you'll see some of the survey guidance for DIA and CMS requirements here. So phase 3, again, is going to look pretty similar in terms of the things we're looking for. We're looking for 14 days, again, so that'll be another 14 since the last case, making sure that our staffing and PPE and hospital, relationships and ability to accept referrals and transfers is sufficient, making sure that we're still capable of cohorting appropriately, that we're still seeing a downward trend in the number of cases or percent positivity, sharing that information, through the RMCCs, and then again, just, recognizing that if there needs to be a slightly more restrictive, that depending on the facility, that may be appropriate. So for visitation here, again, we'll see this loosen up a little bit more. So, thinking about a way to set a schedule with specific hours and locations and the number of visitors and visits that are allowed, still reinforcing appropriate infection control practices, which is going to include hand hygiene, trying to think about having really specific designated areas where you can be safely social distancing, and again, cleaning those kinds of areas. And then, thinking about still when appropriate and when it works for everybody, using things like outdoor or more open spaces, or, even, to some extent, if you wanted to, some of the remote contact would still be appropriate. And then making sure we're still screening individuals when they're entering. Again, seeing just a little bit more in terms of personnel that are allowed in and out, and making sure that when that is happening, that we're screening them appropriately and taking, precautions as necessary, and always performing, good hand hygiene. Again, similarly, in the non-medically necessary trips, seeing a little bit of that, if needed to move in and out, but keeping in mind that, part of this is related to surveillance. So still using the cloth face coverings and still having the ability to keep an eye on individuals who are moving in and out. And then seeing a little bit more expansion here under communal dining, continuing to screen and continuing to make sure that we've got facility staff using face coverings, and that facility staff who are interacting with residents are using the appropriate PPE for those interactions. And then again, making sure that we have dedicated space if we need it for cohorting individuals who would become positive, and then having a way to group together individuals who may be new or readmissions with an unknown status. Still somewhat limitations, in group activities, but recognizing that they can occur as long as we've got social distancing, hand hygiene, and cloth face coverings, in place. And then allowing, some more of the salon or beautician or barber visits that we discussed earlier, but still with, those sanitation and, hygiene measures in place. And then again, similarly here, wanting to recognize that we need to keep a close eye out. We want to be doing this slowly and safely, and that if we, recognize and it confirms staff or resident with another symptomatic individual, we'd want you to go back to phase 1 with the idea here that we want you to, be thinking about, again, sort of increasing some of the infection control measures and limiting potential for this virus to move within your facility. And then, we've got a note here that just sort of recognizes for many of you, we know that things can be a little complicated in terms of an association with perhaps an assisted living program. And I think many of you have worked through, ways to kind of navigate those relationships, but just acknowledging here that sometimes we know there are shared spaces or services, and it's something to keep in mind as you think about the plans for those locations as well. And if you need additional help on that, we can help with that. So I want to turn now to testing, and I'm sure you're aware that there have been a variety of sort of discussions around testing and how to use it in these settings. And I think that one of the things that we've recognized, as these resources have become more widely available, we think that they can be very helpful in getting a better understanding of what's going on at a facility and helping to target things like cohorting, certainly appropriate use of PPE, and monitoring of virus activity within a facility. And so to begin with, and we know that there are many facilities out there who have already done this, but we did want to make sure that we're offering to all of you, to all of your facilities, that if you haven't yet done so and want to offer, a one-time comprehensive baseline testing to your staff and residents, that's something that we can support you on and that we would recommend. I think it's important to keep in mind that when we do that, we need to have plans in place for how we're going to be, moving residents if necessary and addressing workforce challenges if necessary. But we do recommend, if you have not yet done so, that you consider performing this kind of baseline prior to starting to move through these phases so that you have a good understanding of what the current situation is in your facility. Now, I think, as we've talked about before, it's important to recognize that when we do this, that's always going to only be a single point in time. And so it's important to keep in mind that we also want to absolutely continue to offer and support testing of any symptomatic staff or resident. And so we're going to continue to do that. We're also going to continue to offer to support testing when individuals are transferred out of the hospital back to a long-term care setting. And we're also going to offer support on testing to follow up on when a case has been identified or when there's a cluster in your facility. We'd like to support you in performing regular testing of an appropriate cohort to help make sure that you're not detecting additional spread. So by that I mean, if you've identified a case, we'd like to then offer, whether it's a hallway, a unit, the facility, depending on how you're set up, testing for you, and then continuing to repeat that on a weekly basis until we don't detect any additional cases as a means to help inform the spread that you're seeing and to help you implement control measures and things like cohorting. And so I think, that kind of covers what you'd see here for these two sets of bullet points. I think one of the things we want to keep in mind, we're offering this testing, so if individuals were to decline it, just keeping in mind that we want you to make sure that, people are using appropriate PPE and being managed as if their status is unknown. And if somebody has been exposed, certainly if somebody has had a known exposure, that might become an individual who would need to be excluded if they're ill. So just keeping that in mind. And then I think, lastly, one of the additional places that we'd like you to think about, your interest in would be around what we call sentinel testing. And so, many of you are probably familiar with this kind of approach. It's something that we take with flu, and it kind of just means that we're keeping an eye out regularly, whether or not somebody sort of suspects something. And so the way that this would work, and again, we'll be reaching out to a couple of facilities, and if this is something that you think you might be interested in, you can let us know. But we're going to try and look at geographic representation, ongoing virus activity, other availability of testing that you might have, and taking into account sort of overall testing efforts and resources to help work with a couple of facilities who would basically offer routine testing to staff members who are not currently ill, with the idea being that this is one way that we might be able to gain some early insight if we start to see virus activity pick up in particular areas. And so I think that probably wraps up this document. And I think the only other thing I would say here is just that we recognize, again, as always, that, there's been a lot of information coming out very quickly. Things continue to evolve. We want to continue to support you in ways that make sense and in ways that, you know, are based on good public health guidance. And, you know, those things may continue to be adjusted over time, but we continue to be very grateful to everybody for all of your work and are looking forward to making sure that we can find some safe ways to appropriately ease some of these control measures. And so I think that probably takes us to our question and answer time frame here. And if you haven't or are not familiar, I think you know, you can type into our question and answer box or our chat box here.
Just Q&A. You can't access the chat.
Oh, I apologize. So just the Q&A. You'll want to type into the Q&A panel at the top of your screen. There's a question: do we really need to test all staff and residents in order to advance to the next phase? So I can tell you that this is not necessarily a requirement. It's a strong recommendation. And the reason we make this recommendation is because it's possible that you could have somebody who is asymptomatic. And so as you start to ease things and introduce more movement between people and in and out, I think it would be helpful for a facility to know ahead of time, you know, if they thought they had an individual who they wanted to make sure that we cohorted and are using appropriate infection control practices around. And so that's where that recommendation is coming from. There's a question about, do we need to test all independent living residents in order for the nursing home residents to go to certain areas? No, I don't think it's necessary that you would have to test all the independent living residents, because, and I think what you're getting at is that there's the potential that they could interact with each other in some of these settings. I think it's important to recognize that they could interact with each other and to take into account the other pieces of the guidance, right, which do still talk about ways to limit some of those external trips, use screening, use of hygiene, social distancing, and all of that. So I think just keeping in mind, you know, as that movement happens in and out, those are potential points for introduction. And so just wanting to acknowledge that and put as many sort of protective measures in place. There's a question about how to go about doing testing, baseline testing. And so I think, you know, that's something that would be facilitated, you know, through the state hygienic laboratory. And so we would probably want you to reach out through your EMA to make that request. Let's see. So there's questions again about baseline testing, and again, the time frame of that. Yeah, I think, you know, we can provide a little bit more guidance for you on how to exactly go about that, but the idea here would be that, yes, this would be facilitated by the state hygienic laboratory. There are some concerns about the timing of that, and I think depending on the request that we receive and how many of your facilities have already performed this, we'll be able to give you, you know, as you make those requests, an estimate of the time frame. And certainly if people wanted to explore, you know, outside opportunities for doing that kind of testing, you're always welcome to do that. There's a question about, in theory, we could be phase 1 today, then 2 weeks go to phase 2. Yes, that's right. Let's see.
There's a question about providing a list of positive cases to the communication center. I'm guessing that means law enforcement. How do we get people removed? If you want to just follow up with us, I think this is a county-specific question.
Let's see. There's a question about 14 days since the last positive or suspected case. Right now we're saying yes, we would like that to be among staff and residents. There's a question about exposure for healthcare workers now 15 minutes without PPE or even with PPE. So I think, and I know.
Yeah, so the new guidance is posted. It's on our website and it's on CDC's website. So The way that it's being defined now is for healthcare providers that have been within 6 feet for 15 minutes without proper PPE, and that the PPE details are listed in that chart that I went through, then they would need to be excluded as long as the workforce was able to absorb that person being off work. So that's the guidance. It's about people with healthcare workers that don't have proper PPE on, who've been in what's being termed prolonged exposure, and the criteria is within 6 feet for 15 minutes.
There's a question about the recommendations state that communal dining and activities are not recommended, but must be limited for COVID-19 negative or asymptomatic residents. Does it also include those who have recovered? Yeah, so I think if the question is whether you can include those in the group, yes, I think you can. I just wouldn't treat them differently, right? So we don't yet know in terms of immunity, you know, what that means, you know, based on recovery. So I don't think we can make any assumptions, for example, that they're not, you know, that they are or are not immune, but I think you can include them in that group. Let's see, on page, there's a question about comprehensive testing is encouraged. If you decide not to do it, are there repercussions from DIA? I don't believe so, but we can clarify that for you. There's a question about, I want to confirm the exposure. I think we already, did we already answer this? Okay. How will IDPH be notified? IDPH and local public, how will and how?
Yeah, so there's a question from a local public health partner wanting to know if they'll receive notification if a long-term care facility in their county is doing sentinel testing, and if there's a, we'll notify all local public health departments if facilities within their counties become sentinel testing sites.
There's a question about local public health providing other facility types with baseline testing or with additional test kits. I think if there are requests that a facility, if a facility is making a request because they need to perform testing, I think those are still fine to submit those requests through your routine procedures through the EMA. So I don't think that's a problem.
Through WebEOC.
If an asymptomatic worker who is not a healthcare provider goes back to work wearing a cloth mask and develops signs and symptoms, would the coworkers within the 615 then be close contacts for contact tracing? So
there was a nuance in that guidance that said if the patient was wearing a cloth, can you go back to it? If Well, so if the healthcare providers, okay, so if the co-workers are wearing full PPE, then they wouldn't need to be excluded. If they weren't wearing PPE and they were around this individual, so if they didn't have eye protection on, and the person was not wearing a mask, that would be an issue. I think some of these nuances, let's kind of talk through. This feels a little complicated, but if you have questions, just reach out.
I think and again, I know this, I apologize, I know this is challenging, and we'll share this guidance, and as you have specific situations, please do reach out. But I think the other thing I would just point out is, we want to make sure that the healthcare providers are using PPE. They're using procedure masks or surgical masks or N95 masks when appropriate. I know that, we've gone through a time period with a lot of challenges and, use of things like cloth face coverings, but I think, when we talk about making sure we have adequate supply, we're wanting facilities to make sure that your healthcare providers are using appropriate PPE. And if you're not able to access those supplies, please do make those requests so that we know about them. Let's see.
If a hospital employee who has a negative COVID test and there's no known exposure, do they follow the new guidance for return to work, or do they continue with 10 days from signs and symptoms? And so we're comfortable as we're kind of transitioning to, you know, acknowledging that other illnesses will be circulating in the fall, that if we have a healthcare provider who has symptoms of COVID, or symptoms that could be consistent with COVID, gets tested, tests negative, and they do not have a known exposure to a COVID positive individual, then they can return to work 24 hours after their symptoms resolve, as long as they're, you know, their symptoms are resolved, and that's in accordance with the procedures in place at that facility.
There's a question about individuals who are PCR positive who are asymptomatic continuing to work while wearing PPE. So that's not going to be necessarily the preference. If you're able to sort of, if you're able to have workforce plans to make it so that that is not the case, that's going to be the preference. But if it becomes a point at which you're not able to safely and adequately provide care in your facility, unless you're allowing that positive asymptomatic individual to work while wearing full PPE, you know, that could be done. That wouldn't be our first recommendation, but we would recommend that those individuals work only with your positive COVID patients to further limit the likelihood that they could be introducing that or making anybody else ill. There's a question about the burden of testing for the state if all facilities are wanting to sort of do this. And again, I think it's a good question. I think it's an important question. It's going to depend on, you know, we know that there are many of you who have already done this. We want to make sure that we're making that offer clear. We're going to work with you as you receive those requests. And certainly, you know, as always, you know, depending on the volume and what we're able to do for you, there are always alternate opportunities for testing if that is more appropriate for your facility. There's a question about being able to choose a nasopharyngeal versus a nasal swab. I think it will depend in part on, you know, the supplies that we have, but we can work with you when you make that request. There's also a question about serology testing. I think that's a great question. You know, if we're able to, we would love to be able to facilitate that for you. So please, you know, again, I would make that request through your EMA. Let's see. So there's a question about how far back does baseline testing go. So the baseline would be, you know, going back to the beginning of this response. And I think this person is specifically asking about April. You know, I think that's fine. I think the question that we're trying to get at is whether you've done a baseline assessment. There's not going to be a specific time period in which you have to do it. We want to make sure that we offer that to everybody with the understanding that we think it's helpful to help you understand the current situation, but whether it's done in April or whether it's done today or whether it's done, you know, in a couple of hours, we have to recognize the limitations of the fact that the testing does represent a single point in time. And so in addition to doing something like baseline testing, we want to have all those other pieces in place so that we're able to, you know, catch cases early and respond appropriately. Again, you know, I would reach out to your EMA.
The question is who should long-term care facilities contact if they want testing? Again, we're going to put together a quick guidance document and send that out as well so it's clear to everybody.
Let's see.
There's some questions about staff screening procedures. Specifically, is it okay for staff to take their own temperature and mark down on a piece of paper that they give to their manager that they're symptom-free? I think the preferred method would be to have someone there that's doing the assessment. However, we've not been prescriptive on how that needs to occur, so there's some flexibility there for facilities to decide what works best given their setup. But again, the preferred would probably be to have somebody there screening staff when they come in.
There's a question about in regards to 14 days, is it the last positive case or last symptom? Does it apply to residents or staff or both? And if you've had none, do you need to do baseline testing? So the recommendation for baseline testing is across the board, whether you've had a case or not. That's still our recommendation. The 14 days would be from the diagnosis of your last positive case. So yeah, the date of the specimen collection from that last positive case, and that would apply to staff or residents, so not based on symptoms, but based on date of collection. There's a question about if you've not had a confirmed case, how can you move through the phases? Again, I think I would take a look at those criteria for phase 1 and phase 2. I would assess whether you have all of those things in place, including adequate PPE and workforce supplies. I would assess whether you have plans in place, whether you've done baseline testing, and whether you have plans in place for how to test if individuals become asymptomatic. And if you meet all of those criteria, then you're able to move through those phases. There's a question about, does the guidance apply to assisted living? Again, I think for some facilities, they may want to, use some of this, but this is really aimed at long-term care settings. And so, assisted living facilities, may choose to follow some of this or adjust a plan if they need to, if it's appropriate. Is the shift to phase 3? Skip to. So there's a question about, is the shift to phase 3 14 days after the shift to phase 2, or can you go straight from 1 to 3? No, it is from phase 1 to phase 2 to phase 3. So yes, there's 2 14-day intervals in that time period. Are there differences in the metrics? No, it's actually, so the question is, are there differences in the metrics moving between phase 2 and phase 3? No, it's that you want to allow another 2-week period to elapse and make sure that you still meet all of those same criteria. And that, that would be, those things that include decreasing case counts, decrease in positivity in your county, adequate PPE, adequate workforce, making sure you have plans in place and access to testing, making sure that you have plans for hospital transfer. For healthcare workers who are not within 6 feet of patients, do they need to have a procedure mask? No, the PPE, when I'm speaking about making sure that everybody's using procedure masks and N95s, I mean as directed for patient care. So that's not related to people who would not be within 6 feet of patients or providing patient care.
Yeah, I think take a look at that guidance. There are some exceptions for if these individuals are within 6 feet of patients, but to your question, like Dr. Padati said, if they're not within 6 feet of patients or infected individuals, then the cloth mask is sufficient.
Let's see, there's a question about, is there anything beyond phase 3? And it's a great question. I think that right now that is as far as we would plan to go. But I think that what it will be related to is what we see happen with this virus in the future. And some of that, unfortunately, it's just a little bit unknown. So it's not clear if we're going to see increases in activity or if we're going to see this virus become part of respiratory virus season. But I think that right now, this is sort of as far out as the plan exists, but we will certainly be making additional adjustments as we get more information and as we have more, information about the trends moving forward. There's a question about repeat testing on individuals for positive. No, that's not something that we recommend. We are aware that there are individuals who sometimes can be positive for a while, and part of what I think is important to understand about that is the PCR testing that we're doing is pretty sensitive, which is a good thing because it helps us find cases. But just like other PCR tests, sometimes we know that we can find fragments of genetic material that perhaps aren't consequential. So, for example, when you think about the release criteria from CDC, you can either follow a test-based strategy or a symptom-based strategy. And the reason for that is because CDC has done some work testing individuals by symptom and also by timing. So looking for how the PCR lines up with detection of virus that you're able to culture, which would suggest that it's able to infect somebody. And what they found was that the ability to culture that virus drops off around day 6 or 7, and so, really by the time you hit 10 days from your positive test, we don't think that we're detecting anything that represents a risk to other people, and so that's where that recommendation comes from. And so there's not a current need to perform repeat testing on individuals who are positive. Let's see. I think we've maybe only got time for a couple more questions here.
We've got a lot of repeat questions here, so we're just kind of flipping through to see if there's any new ones. Yeah, there's a question, is there a form for counties to use when working with a long-term care facility and doing follow-ups when they get cases? And that form is the IDES form. It's the case form that's in IDES. If you have questions about that, reach out to your field FB, please.
Okay, let's see. There's a question about, do staff who decline testing need to be off for 10 days from the date the testing is conducted? No, I don't think it's that they need to be excluded from the date that the testing is conducted. I think you just want to keep in mind that you wouldn't know, right, whether that person was infected and asymptomatic or not, and so you just need to make sure that we're taking appropriate precautions, and keeping an eye out for development of illness. Again, there's a question about the necessity or the utility of baseline testing. Again, the idea is that even though it's a snapshot in time, it can tell you if there may be people who are asymptomatic in your facility, which helps you identify them and isolate them and then sort of respond appropriately by either cohorting or using the right PPE before you have additional movement in and out or within a facility.
There's a really good question here, and I should have clarified that. I apologize. The question was, I thought IDPH said asymptomatic positives, we should go back 10 days prior to the day they were tested to find close contacts. And that is still the case. That is absolutely still the case. In this guidance that CDC put out, they're saying for a healthcare setting, is you can go back 2 days. And they're saying that they did that because of just workflow issues. So that is different guidance. We acknowledge that. And we still would like you to go back 10 days from the time of the test to find those close contacts. But in a healthcare setting, they're saying, again, if the individual had a known exposure to a positive person, you go 2 days after that known exposure for the starting point, or if you don't know, 2 days before the test. So I know that's confusing and that feels funny, but that is the guidance.
Yeah, and again, we recognize that there's been a lot of changes made recently and a lot of guidance coming out, from us, from other organizations, from our federal partners. And I think, again, in a way, these are good things. This represents additional knowledge and additional information that we can use to keep everybody safe. But we know it's a lot. We know we've only had an hour here today. And again, we're really grateful for everybody's help. If we weren't able to get to all the questions, please do reach out to us directly. We want to follow up. We want to work with you and hear about additional challenges or places where we may need to make adjustments. We're absolutely going to continue to remain flexible on this. And, our goal here is really the same. We want to make sure we're doing everything we can to support you all and making sure that we're taking care of everybody, your staff and your residents and your facilities, because we know this has been just an incredibly challenging time. And again, I'm so grateful to everybody for all the work you've done. And with that, I do apologize. We are going to have to conclude today's webinar, but like I said, thank you again, and please do reach out. And we want to continue to hear, feedback and work with you on questions around this. So thank you all.